Now we're going to change gears a bit, and we're going to talk about menopause and hormone management. Now, our next speaker is Dr. Kelsey, and she's an obstetrician gynecologist like I am. She specializes in challenging cases of hormone treatment in trans care and premature ovarian failure and cancer-associated menopause. She's given numerous talks, presentations at meetings. I have to admit, I've met her the first time today. I've never met her in the past. And if you guys wonder how is that we're in the same discipline, I think just wait until she's on the stage, then you'll realize why I've never met her before. So Kelsey is a North American Menopause Society certified practitioner since 2013. He's a member of the World Professional Association of Transgender Health. She's the recipient of the Canadian Menopause Society Young Scholar Award. She's also author of the most recent, brand new 2021 published guidelines by the Society of Obstetricians and Gynecologists for the treatment of menopause. So, ladies and gentlemen, please welcome to the stage Dr. Kelsey Mills.
Thank you so much for that kind introduction. I think Dr. Duplessis is referring to the fact that perhaps we are of different generations. But I told him I'm really in my late 70s, I'm just a hormone expert, so there you go. I'll just hit presenter view, and that should be it, right? Perfect. Excellent. Thank you so much to Jane and the Seashell Hospital Foundation for this kind invitation to speak to your community. I'm thrilled to be here. As Dr. Duplessis said, I practice in Victoria. I also just wish to acknowledge that today I speak on the Sunshine Coast, which is home to the traditional unceded ancestral territories of the Skohomish, Sechelt, Sliamon, Klahus, and Homolkos peoples whose historical relationships with this land endure to this day. And I also thought I would just mention that as a gynecologist, I spend most of my time referring to women, and I'll refer to women in this lecture for simplicity of language. It also recognizes that the vast majority of studies done on menopause and hormonal health have been done on cisgender, usually white females. But I do want to recognize that non-binary, two-spirit, and trans men may have ovaries and uteruses and can experience issues as they transition in their lifetime, and I wish to be inclusive of them, and I'm happy to take any questions at the end. So today, I told Jane I really wanted 3.5 hours to talk, but in my 25 minutes, I'm going to try to provide an overview of body changes that can occur during the perimenopausal transition. I'm going to try to review symptoms that many people in this room may be very familiar with. I'll discuss an overall sort of a brief introduction to treatment options, and then most importantly, I wish to leave you with some preventative health ideas to have a healthy menopause, because that's what we're all about. So here's my cartoon that says, "I can't wait for menopause, said no one ever." Except that that is actually not a sentiment that's borne out in the literature. And this is an amazing time to be entering perimenopause or menopause, because never before have we had as much advocacy, interest, specialization, and treatment options available for people who are going through this time. And a lot of my patients can find this to actually be an empowering and positive experience. So it's all about your frame of mind. So what is menopause? It's always fascinating to me that people will say, oh, I did it, or it never happened, or I'm through it and it's over. But menopause is a normal and natural life event for women. And once you are in menopause, you are menopausal for the rest of your life. Some women can experience severe, very impairing symptoms, and we're going to talk a bit about that. And it is a retrospective diagnosis that we make 1 year after the final menstrual period has happened. And it basically results in a gradual loss of ovarian follicular function as we age. And in North America, the average age for that to happen is about 51.4. And because women's life expectancy is so incredibly long, women will now expect to live a third to even up to a half of their life in menopause. Yet many of my patients will tell me that they were only taught about how to either not get pregnant or how to get pregnant. And then once that was finished, nobody talked to them about living a healthy life for the other half of their life. So hopefully we'll do that. So menopause can also occur prematurely. This is a great passion of mine, is helping these women due to medical causes, such as removal of the ovaries, undergoing chemotherapy or radiation, and early menopause is what we consider under age 45. There are a very small group of women, less than 1% of the population, who go through menopause under the age of 40, and we sort of investigate those women to understand why. That can happen due to genetic causes or autoimmune disease or idiopathic, which just means we haven't found the answer yet. So as we age, our ovaries age, they begin decreasing in size, and if you have ovaries, you had your peak number of eggs available to you when you were 20 weeks old inside of your mother, and then you had about 1 to 2 million eggs available when you were born, and then they are ovulated, and then by the time we enter menopause, there are about 1,000 left. And as a result of this aging of the ovaries and the egg basket, then we start to see changes in hormonal levels and hormonal function. And so over time, as women age, we see decreasing circulating estrogen levels. We see an increasing level of something called follicle-stimulating hormone, which is the signal to our brain that drives the brain to say, ovulate, release an egg. And our brain has to try harder and harder to do that the older we are. And at the first, as we enter perimenopause and menopause, there is no significant change in testosterone levels, but over time, those will fall also. So I wanted to briefly talk about abnormal bleeding in perimenopause, and this cartoon says, hey, your period finished today. Just kidding, because many women may have personally experienced or recall that having erratic bleeding as they're entering the menopausal transition is one of the hallmarks of entering menopause. And if I leave you with any take-home message, I want to remind all women that once you are in menopause, after not having a period for a year, if you have any bleeding, that needs to be brought up with your doctor. Bleeding in menopause is never normal or okay. So there are many causes of bleeding as women enter the menopausal transition. Pregnancy. I did deliver a 52-year-old about 6 months ago. Fibroids, uterine or cervical polyps, hormonal changes, as we've spoken about. The use of different hormonal devices or pills, patches, rings can certainly change bleeding. And then what we are always thinking about are cervical disease or uterine disease. And just because Dr. Gordon was here, I had to put up some radiology pictures. But as physicians, these are some of the things we're looking at when we're investigating causes of bleeding in menopause. So we're looking for polyps in the uterus, we're looking for fibroids seen on that MR image, or we're looking for endometrial disease. And then how we manage that bleeding is based on what's causing the bleeding. And we have lots of medical options in gynecology, which is why it's an amazing time to be a woman if you're going to have some of these issues. Gone is the day where everyone who had an issue ended up with a hysterectomy. There's so much more that we can offer women. And then as women enter menopause, the hallmark symptom that is most commonly talked about and discussed are vasomotor symptoms, and that includes the constellation of symptoms which include hot flashes or night sweats, which also includes sleep disturbance as a result of that. So this is not rare. And I tell the medical students, menopause and menopausal symptoms is not an esoteric topic. This is going to affect 75 to 80% of all women. So we have to understand this, and we have to have an approach to be able to talk to people and to help people. And we know that vasomotor symptoms are associated with a poor health condition and poor health status. They can significantly impair work productivity of women, and they can significantly impair quality of life. And one of my favorite comments that my mentor often commented on was when they compare quality of life studies in women suffering from severe vasomotor symptoms, those quality of life markers are on par with people who are living with end-stage kidney disease. So these women are having severe difficulties, and there's a lot we can do to help. So when women are experiencing hot flashes, the number of the episodes can vary. Some women say, yeah, I think I had one of those one time. They don't end up in my practice. And then there are some women who flash every 10 minutes. And it is extremely challenging to be able to cope when you're constantly sweater on, sweater off, waking up 15 times overnight, soaking the sheets, lying on 2 towels to absorb your perspiration, going bright red when you're trying to, have a professional conversation with colleagues. It can be extremely challenging. This often occurs in its highest occurrence and intensity and frequency during perimenopause and for the first 2 years after the period has stopped, and can be severe in up to 10 to 15% of women, which is a big chunk of the population. We used to say, oh, it'll last a couple of years and you'll be fine, but the recent data actually suggests that women will experience their symptoms on average for 7 to 8 years. So this is a long time that women may have to deal with this. And there are some women who will flash for the rest of their life. And so we have to be aware that how are we going to offer help to those people as well? What factors contribute to experiencing vasomotor symptoms? So anybody in here who is in that phase of life will be able to agree that when you're in a warm environment or bring warmth towards the face, it can trigger a flash. Dietary triggers such as hot drinks, spicy food, alcohol, particularly red wine, can be a major trigger for a lot of women. Stress, emotion, surprise, carrying extra body weight can worsen your vasomotor experience, cigarette smoking, and then certain administration of drugs, certain breast cancer drugs like tamoxifen in certain situations, depression, anxiety medications can also increase challenges with this. So how bad can it get? I have permission from one of my patients to show this slide. What she did was she tracked on a piece of paper every time she experienced a hot flash or a night sweat. And you can see on there that she was up, every hour, usually less overnight. And so then you have to wonder to yourself, how are women supposed to function and lead professional lives, manage their families, help their ailing parents, have hopes of having good mood or anxiety control, have an attempt in a meaningful relationship with a partner if they have no sleep quality due to this. So this is a real issue. And there are lots of lifestyle management that people will try. The cold showers, managing the room temperature, dressing in layers, avoiding alcohol and spicy foods, pulse respiration or boxed breathing, and there's lots of videos online on how to do that. The acupuncture literature, swings a bit, but people find that helpful, using fans, etc. But for many women, the conservative options just aren't enough. And then what I think it's important to understand is that menopause is not just hot flashes, and I see a lot of patients with complex symptoms that perhaps never thought that some of these were due to the fact that now their hormone levels have really fallen. And some interesting ones that I think are really kind of go under the radar include new onset joint pain and stiffness, palpitations, and women who have never had an anxiety issue before, who turn 55 and all of a sudden are having a very difficult time coping. So, I see these all the time, but I've left this list here for you of some of the things that can be associated with hormonal changes, and we need to talk about them. So something that I'm really passionate about, which we never talk about because we have difficulty talking about women's bodies, although we're getting better, is genitourinary syndrome of menopause. So this is a term that includes a constellation of symptoms that includes pain with intercourse, vulvar and vaginal dryness, bladder irritation, recurrent urinary tract infection, and this is common. And it's easily treatable, and women, in my experience, sort of suffer silently, thinking that this must be normal or okay. But as women go through menopause, the withdrawal of estrogen affects all of the body, and there are significant tissue changes that can occur in the lower tract. Unlike vasomotor symptoms, in which if you bear with it long enough, they'll probably go away, these symptoms of the lower tract in the vulva and vagina and bladder are progressive and cumulative and are unlikely to go away unless we do something about them. And so there are non-hormonal things that we do, and certainly if people are having regular intercourse, that can be a good way to promote blood flow to the genitals. However, it's very difficult to even have intercourse in the first place if you have severe dryness or pain. So water-based lubricants is for intercourse, moisturizers are for daily use for comfort, and these can be an amazing way to bring comfort to the area. Self-stimulation or use of a vibrator or dilator can also help tissue strength. It can maintain the vaginal caliber, because as women age, things do get narrower and narrower, which can cause more and more pain. And then having good vulvar hygiene measures can be important too. But we don't talk enough about these things, but the current studies on this would say that over a woman's lifetime, up to 80% of women will struggle with these issues. And we have lots of incredible treatment options, which is why it's a great time to be a woman in menopause. We have 3 new medications that have been Health Canada approved, 2 of which are already brought to market very recently within the last year. So we have local hormone therapies which are safe. They do not increase the risk of breast cancer, stroke, heart attack, clot, or other issues. I'm talking about hormones that are put in the vagina or on the vulva, and these can restore vaginal blood flow, decrease the pH, improve thickness and elasticity of tissue, and these are the mainstay of treatment and can really, really help people. And this is a cartoon just showing all of the parts of the lower tract that are impacted by menopause. And I think there are a lot of people who suffer silently until they get to a point. You know, I have patients in my practice where they're on antibiotics every 6 weeks for another UTI, and then we put a little bit of hormone in the vagina, and they never use antibiotics again. So this is something that I think also deserves our attention. You know, mood in menopause is another great topic, and you know, that's the topic that you could spend 5 hours. You could do a whole MedTalks week on this topic, but this is important also, and this can be a major change and shift for women as they enter this time in their life. And why is that? Because there are so many stressors in the midlife. Women are aging chronologically. There is the loss of fertility, which for some people is very grieved. There are sleep problems, which we've already spoken about, and sleep and mood are deeply tied into each other. There are medical concerns which cause stress in the life. There could be divorce or loss of relationship, empty nest, being part of that sandwich generation in which you're dealing with your college children who make you crazy, but also your parents are really ill and you need to help them. There can be career issues or sexual function concerns, and all of this can weigh down on the woman in the midlife, and it's no wonder, you know, that mood or anxiety can be an issue. And there are lots of things that can be helpful for this. The biggest recommendations are around cognitive behavioral therapy and stress management, but there can sometimes be a role for hormone therapy or other therapies to help. I'm going to speak briefly about hormone therapy. This is not the best venue for me to talk about specific types of hormone therapy for specific indications, but if there are particular questions, I'm happy to help. So this is just a timeline, because hormone therapy is a very, shall we say, complex topic in which menopause was first described as an endocrinologic deficiency disease in 1933. And then in 1942 were the first oral estrogens that came on the scene, and that oral estrogen is still available for purchase and use in Canada today. There was this era of menopausal hormone therapy use up until 1999, and at some points in the United States, 21 to 25% of all menopausal women were taking some form of hormone therapy. Then there was publication of the Women's Health Initiative trial, which is a very contested, very complicated trial, which gave us a lot of information, but following that trial, which brought into question the role of hormone therapy and its relationship to breast cancer, heart disease, and stroke, almost all women came off their hormone therapy, and there was this period of uncertainty in which we saw, as the hormone therapy prescriptions went down, menopausal women were put on antidepressants, and it's almost a perfect relationship. Now, since 2002, we have had a lot of research and a lot of analysis of specific groups of women, and what we understand now is that when we take healthy women who have significant symptoms, who are under the age of 60 and within 10 years of their final period, giving hormone therapy for moderate to severe symptoms is the standard of care and is a safe option. Now, this is a chart showing benefits and risks of hormone therapy, and we can see reduction of vasomotor symptoms, improvement of sleep, reduction of mood and anxiety, reduction of cardiovascular disease and all-cause mortality, osteoporosis prevention and treatment. And on the risk side of things, and this is where I spend all my time when we counsel patients, are thromboembolic events and stroke, particularly in high-risk patients. And these are usually looking at women over the age of 60 or who have pre-existing risk factors. There is an association with breast cancer, which I'll speak to a bit more, after women have been on combined therapy, estrogen and a progestogen, for more than 5 years, and coronary artery disease or endometrial disease in women who are given hormone therapy inappropriately. There are some contraindications. Hormone therapy is not for everyone, and the biggest one that affects the biggest amount of our population are women who have had a breast cancer. And we can get into the details of this, but there are two broad groups of breast cancers, the hormone receptor positive and then the triple negative breast cancers. And we used to think that perhaps it was okay for women who had had triple negative disease to consider hormone therapy, but our recent guideline that just came out in 2021, when we actually look at all of the data sets available to us, our statement was that women who've had any previous breast cancer should not be on systemic hormones. That's taking a pill by mouth or using a patch or a gel on your skin. That's not necessarily inclusive of the vaginal hormones that I spoke about before. So the North American Menopause Society just released, this came out I think last month, their 2022 hormone therapy position statement, and they continue to express that hormone therapy is the most effective treatment for vasomotor symptoms, as well as local therapy for vaginal dryness, and we know that it prevents bone loss and fracture. Benefits are most likely to outweigh risks for symptomatic women who start hormone therapy under the age of 60 within 10 years of the menopausal onset. So I'll speak briefly about breast cancer risks, and I'm thrilled to present today on the same panel as Dr. Gordon, because breast cancer is one of my areas of interest. And I'll show the same slide she did, but for a different reason. So this is the same study showing that as breast density increases, we see the relative risk of breast cancer go up. And why this is important in menopause land or hormone therapy land is because different types of hormone therapy treatment can impact breast cancer differentially. And so when we're providing hormone therapy to women, we're looking at their risk factors for breast disease, we're counseling on that, and then we're trying to help women make the best decisions because there are some options for hormone therapy which may not impact breast cancer. We know, for example, that if a woman has had a hysterectomy and is taking estrogen by itself, that does not increase her risk of breast cancer. So there's a lot of nuance around this, but it is from this breast density conversation, which is why today is so fitting, that we get the concern of breast cancer risk in terms of using hormone therapy. But also, as Dr. Gordon alluded to, a woman's risk for having breast cancer is multifactorial. And this is sort of a de-escalating slide looking at if you have that BRCA1 gene mutation, your relative risk of getting a breast cancer is 200-fold the baseline population risk. Whereas if you use estrogen and progesterone therapy for more than 5 years, you're increasing your breast cancer risk basically on a similar level as if you have postmenopausal obesity or drink more than 2 units of alcohol a day. So these are low risks, not zero, but low, but it's important for women to understand where they fit in terms of their personal risk model for breast cancer. So for the people in the audience who are, wondering about their menopause, maybe starting to think about what their health picture looks like, this is an article written by a friend and colleague of mine who's a family physician in Toronto, and she wrote these 6 questions that women should be asking themselves and perhaps posing to their healthcare provider as they go through the menopausal transition. Because there's a lot to talk about and there's a lot of help to be had if you are one of those people who is struggling silently. So have you had any changes in your periods? And I'll remind you again, if you've had any bleeding after 1 year of no period, that's abnormal and needs an investigation and workup. Are you having any hot flashes? Are you noting any vaginal dryness, pain, or sexual concern? Because these are common, and it is okay to bring these up with your provider. They know how to start this conversation. Any bladder issues or incontinence, because we always say that bladder issues and incontinence are common, but not a normal part of aging, and there's a lot as well that can be done about that. Are you having sleep concerns, and how is your mood? So these are the 6 sort of spheres of menopause that we're thinking about. And then when women are thinking to themselves, well, what can I do? You want to live to be 100 and be really healthy? Well, here are some key points. So maintaining a healthy body weight is really important, and that is important in terms of breast health, but also for so many other indicators of health. So eating the balanced diet with portion control, focusing on protein. Our recent guidelines are really highlighting the role of vegetables in the diet because, it's been shown that we don't eat enough vegetable in our diet. Obtaining adequate calcium through the dietary means preferentially, and then vitamin D as a supplement. Weight-bearing exercise and weight training is really important, a great way to maintain health. And we talk a lot about osteoporosis and bone loss in menopause, but what we also need to be talking about is a topic called sarcopenia, which is muscle wasting and muscle loss. And together, sarcopenia and bone health contribute to fall risk, and falls are important. We know that at 1 year, if 100 women have a hip fracture, 20 of them will be dead in the next 12 months. And that if they did not have surgical repair of that hip fracture, 70 of those women will be dead. So maintaining our flexibility, maintaining our strength, and doing that through strength training exercise and instituting measures to prevent falls are really important. I've harped enough about alcohol, but I always say in every talk, do not come to me to tell me about your midlife weight gain, your problems with your sleep, your challenges with your vasomotor symptoms, your impaired sexual function if you're drinking, in excess, because all of those things are affected by excess alcohol consumption. Nobody wants to hear that. I know, it's amazing that I still have friends, I know. How else can we have a healthy menopause? And one of my colleagues said, Kelsey, I really think my wife should see you. She's got a bunch of problems, but she's afraid because she knows you're going to tell her to stop drinking. I said, well, How else? So getting a good sleep and having good sleep hygiene, moving your body in nature every day. I know that sounds like a crunchy granola Victoria thing to say, but it is evidence-based. Following cervical screening guidelines until age 69, following breast screening guidelines, as Dr. Gordon so eloquently discussed today, a reminder that women in British Columbia can self-refer, and I'm thrilled to hear that we're working on the provider problem. Having a routine bone density at age 65 for all humans, not just women, and following your local colon cancer screening guidelines. And then finally, I do encourage people to consider a meditation and or gratitude practice, because at the end of the day, we have this one life. So if you have any questions, I'm thrilled to answer them at the end. The first website is a website that I've built with my group that has podcasts, patient handouts, guidelines, all in PDF form if you're looking for good quality curated information about menopause. And then I encourage you to check out the Menopause Foundation of Canada, which is a nonprofit advocacy group looking at improving education in curriculums and in the general public. Thank you so much for the invitation.